Hello everyone, and a very warm welcome to Noel's Review, Best Family Nurse Practitioner Certification Exam Review Online. My name is Marie, and I am absolutely thrilled to have you here with me today as we embark on another crucial step in your journey toward professional excellence. Whether you're just beginning your study regimen, are in the final stages of preparation, or simply looking to sharpen your clinical knowledge, you've come to the right place. Our mission here is simple: to demystify the FNP exam and provide you with the high-yield content, strategic insights, and confidence you need to not just pass, but to truly excel on exam day. Today, we have a particularly special session planned, one that is designed to simulate the real exam experience and test your critical thinking skills under pressure. We will be diving deep into 10 meticulously selected must-know questions that cover a broad spectrum of topics you are likely to encounter on your FNP boards. These aren't just random questions. They have been carefully curated to reflect the complexity, format, and clinical reasoning required by the AANP and ANCC certification bodies. Think of this video as a focused, high-intensity workout for your brain, designed to strengthen your diagnostic muscles and refine your treatment planning abilities, bringing you one step closer to that coveted FNPC or FNP-BC credential. Here's how we're going to structure our time together for maximum benefit. I will present each question clearly on the screen, reading it aloud for you. After I've finished reading the question and its multiple choice options, I'm going to build in a deliberate pause. This is your time. I strongly encourage you to hit the pause button on the video and give yourself a solid 30 seconds, or even a full minute, to really analyze the clinical scenario presented. Consider the patient's symptoms, their history, and the potential differential diagnoses. Formulate your answer, and more importantly, the rationale behind your choice before you proceed. This active engagement is the key to deep learning. This method of active recall is a scientifically proven study technique that goes far beyond passive learning. By forcing yourself to retrieve information and make a clinical decision before seeing the answer, you are strengthening the neural pathways associated with that knowledge. It's about more than just getting the right answer. It's about understanding the why behind it. This process helps you identify your areas of strength and, just as importantly, pinpoints the topics you may need to revisit. So, grab your notebook, silence your notifications, and get ready to challenge yourself. Let's begin this journey together and unlock your full potential as a future family nurse practitioner. All right, let's dive right into our very first question. I want you to listen carefully to the clinical details and visualize the patient as I read. A 45-year-old female presents to your primary care clinic with a chief complaint of a persistent, dry, hacking cough that has been bothering her for the past 6 weeks. She states the cough is non-productive and seems to worsen when she lies down at night. She denies any fever, chills, sore throat, or recent upper respiratory infections. Her past medical history is significant for hypertension, for which she was started on a new medication approximately 2 months ago. She has no history of asthma or environmental allergies. Which of the following medications is the most likely cause of her chronic cough? Here are your options. Is it A, amlodipine, a calcium channel blocker? Could it be B, lisinopril, an ACE inhibitor? Perhaps it is C, metoprolol, a beta blocker? Or finally, could it be D, hydrochlorothiazide, a thiazide diuretic? Take a moment now. Look at the patient's age, the specific character of her cough, dry, persistent, positional, and crucially, the timeline of her new medication. Consider the pharmacological profile of each of these common antihypertensive agents. Pause the video, think through the mechanism of action for each drug, and decide which one is the most notorious culprit for this particular side effect. We will come back with the answer and a full breakdown. This question is a classic example of how the FNP exam will test your knowledge of pharmacotherapeutics, a cornerstone of primary care practice. It requires you to do more than just match a drug to a disease. You must understand the potential adverse effects and how they manifest in a real-world patient presentation. The board examiners want to ensure you are a safe and effective prescriber, which includes the ability to recognize when a prescribed therapy is causing more harm than good. This patient's presentation is not dramatic, but her quality of life is clearly impacted, and it is your job as the astute FNP to connect the dots between her new symptom and her recent medication change. As you deliberate, think about the pathophysiology. What biological process could be triggered by one of these medications to produce a dry, irritating cough? Does it involve prostaglandins? Bradykinin, histamine. Ruling out other causes is also part of the process. The lack of fever, chills, or signs of infection makes a post-viral cough less likely. The absence of a history of asthma or allergies points away from a reactive airway disease. The timeline is your biggest clue here, pointing directly toward a iatrogenic or medication-induced cause. This is the kind of clinical detective work you will be doing every single day in your practice as a family nurse practitioner. Excellent work on that first question. Let's now shift gears from adult primary care to pediatrics with our second question. A 4-year-old boy is brought to the clinic by his mother. She reports that for the past 2 days, her son has had a high fever, up to 104 degrees Fahrenheit or 40 degrees Celsius, and has been extremely irritable. Today she noticed a rash that started on his trunk and is now spreading to his neck and arms. On physical examination, you note a febrile, fussy child. You observe a pink maculopapular rash on his torso. His posterior cervical and postauricular lymph nodes are enlarged and tender. Crucially, the fever broke just as the rash appeared. What is the most likely diagnosis? Consider these possibilities carefully. Is the diagnosis A, measles, also known as rubeola? Is it B, roseola infantum, also known as sixth disease? Could this be C, rubella or German measles? Or finally, is it D, scarlet fever, which is associated with streptococcal infections? I want you to focus on the unique sequence of events described in this vignette. The pattern of the fever in relation to the appearance of the rash is the single most important clue you are given. Pause the video. Think about the classic presentations of these exanthems of childhood and make your selection. We'll be back in a moment to discuss the correct answer and the rationale. This question is a perfect test of your ability to differentiate between common pediatric viral exanthems. On the exam and in your clinical practice, you will frequently encounter worried parents presenting with a child who has a fever and a rash. Your ability to recognize specific patterns is essential for accurate diagnosis, appropriate counseling, and management. Each of the options listed presents with a fever and a rash, but the timing, the character of the rash, and the associated symptoms are all distinct. This is not just academic. Distinguishing roseola from something more serious like measles has significant public health implications, so the stakes are high. Let's think critically about the differential diagnoses. Measles, or rubeola, typically presents with a prodrome of cough, coryza, and conjunctivitis, the 3 Cs, along with Koplik's spots on the buccal mucosa before the rash appears. Rubella often has a more mild prodrome and a rash that starts on the face and spreads down. Scarlet fever is bacterial, caused by group A strep, and is characterized by a sandpaper rash, a strawberry tongue, and is usually accompanied by a sore throat. Compare these presentations to the one in our scenario. The key here is the sequence high fever first, which then resolves abruptly, followed immediately by the onset of the rash. All right, let's dive into our third question, a classic scenario you'll definitely encounter, both on the FNP exam and in your future practice. Picture this. A concerned mother brings in her 7-year-old son, who has been struggling with intensely itchy, red, and scaly patches of skin. She tells you these flare-ups seem to happen periodically and are located primarily on the inside of his elbows and behind his knees. She's tried over-the-counter hydrocortisone with some, but very limited success. The boy has a known history of seasonal allergies and mild asthma. Based on this presentation, what is the most appropriate initial step in managing his condition? Think it over carefully. We'll pause for 30 seconds before we dissect the answer and the rationale behind it. Here are your options for this case. A. Prescribe a high-potency topical steroid like clobetasol. B. Recommend daily use of an emollient and a low-potency topical steroid for flare-ups. C. Refer the patient immediately to a dermatologist for advanced biologic therapy. Or D. Advise the mother to eliminate all common food allergens from her son's diet, such as dairy and gluten. Each of these choices represents a different level of intervention, and your job is to select the most fitting first-line approach for this specific patient. Consider the patient's age, the location of the rash, his personal medical history, and the information provided by his mother. What's the best next move? The clock is ticking, giving you a moment to really process the clinical details. This question is designed to test your understanding of stepwise management for a very common pediatric dermatological condition. It's not just about knowing the diagnosis, which in this case points strongly towards atopic dermatitis, also known as eczema. It's about knowing what to do first. The key here is initial step. We're not looking for the most aggressive treatment possible, but the most appropriate and evidence-based starting point. This is a fundamental concept in primary care. Always start with the safest, most effective, and least invasive option before escalating care. As you finalize your answer, remember that the FNP role is all about patient education and conservative management whenever possible. The mother has already tried an over-the-counter remedy, which gives you a clue about the next logical step up in treatment. The boy's history of allergies and asthma, often called the atopic triad, is a massive clue pointing you toward the diagnosis. This context is crucial. Okay, time is just about up. Let's get ready to break down why one of these answers is the gold standard for initiating care in a patient like this, and why the others are less appropriate at this stage of management. Let's move on to our fourth question, which focuses on pharmacology, a huge component of the FNP boards. Here is the scenario. A 68-year-old male patient with a history of hypertension and benign prostatic hyperplasia was recently started on a new medication to manage his BPH symptoms. He comes to your clinic for a follow-up visit and complains of feeling dizzy and lightheaded, particularly when he stands up from a sitting or lying position. His blood pressure reading in the office today is 110 over 70 millimeters of mercury, a drop from his usual readings around 135 over 85. Which of the following medications is most likely responsible for his symptoms? Here are your potential culprits. A. Finasteride, B. Tamsulosin, C. Oxybutynin, or D. Sildenafil. Each of these medications can be used in the male genitourinary context, but only one is classically associated with the specific side effect profile described in this patient. Take a moment to think about the mechanism of action for each of these drugs. How do they work in the body, and what are their common and predictable side effects? The patient's complaint of dizziness upon standing is a textbook sign. We'll give you 30 seconds to connect the drug to the symptom. The clock starts now. As you deliberate, focus on the key phrase, dizzy and lightheaded, particularly when he stands up. This is the classic description of orthostatic hypotension. The question is essentially asking you which of these medications is known to cause this specific adverse effect. You need to access your knowledge of different drug classes. Consider the receptors they target and how that interaction would lead to changes in blood pressure. The patient's history of hypertension is also a relevant piece of the puzzle, as he is likely on other medications. But the question specifically asks about the new medication for BPH causing these new symptoms. This type of question tests your ability to perform medication reconciliation and identify adverse drug reactions, a critical safety skill for any nurse practitioner. You are the provider responsible for monitoring the effects, both therapeutic and adverse, of the medications you prescribe or manage. The patient's lower blood pressure reading in the clinic further corroborates his subjective complaints. It's a clear signal that something is affecting his hemodynamics. Time is almost up. Have you locked in your answer? Let's prepare to unravel the pharmacology behind this clinical presentation and determine which drug is the most likely offender. Let's proceed to question number 5. This one will test your diagnostic acumen in dermatology. A 22-year-old female presents to your clinic with a new rash. She reports that about 1 week ago, she noticed a single, large, oval-shaped pink patch on her abdomen. She describes it as being about 3 centimeters in diameter with a slightly raised border. Now she has developed numerous smaller, similar-looking pink patches that are spread across her trunk and upper arms. She says the rash is mildly itchy. She denies any fever, new soaps, detergents, or recent travel. What is the most likely diagnosis for this patient's condition? Here are your 4 diagnostic possibilities. A. Tinea corporis, B. Guttate psoriasis, C. Pityriasis rosea, or D. Secondary syphilis. Each of these conditions can present with a widespread rash, but the specific details in the patient's history are your roadmap to the correct diagnosis. Pay close attention to the sequence of events she describes, the initial single lesion followed by a more generalized eruption. The description of the lesions themselves is also a major clue. You have 30 seconds to consider these options and make your choice. Think carefully about the classic presentation of each of these dermatological diseases. As you ponder the possibilities, let's highlight the most critical piece of information provided, the single, large, oval-shaped pink patch that appeared first. This initial lesion has a specific name in one of these conditions, and its presence is nearly pathognomonic, meaning it's so characteristic that it virtually confirms the diagnosis. The subsequent eruption of smaller, similar lesions across the trunk in a specific pattern is another key feature. The patient's age and the mild itchiness are also consistent with the most likely diagnosis. Differentiating these rashes is a core FNP skill. Remember to consider the whole picture. Tinea corporis typically presents differently. Gouty psoriasis has a very specific trigger that wasn't mentioned. Secondary syphilis is the great imitator, but it also has unique features you should look for, particularly involving the palms and soles. Your task is to weigh the evidence and see which diagnosis fits the clinical narrative most perfectly. The description of that first patch is your anchor. Okay, your time is up. Let's get ready to explore the correct answer and understand the telltale signs that lead us to that conclusion. Welcome back to our review session. Let's dive right into our sixth question, which focuses on a common pediatric presentation that every family nurse practitioner must be confident in managing. This scenario involves a young child with a classic set of symptoms, and your task is to identify the most likely causative agent. Pay close attention to the details provided in the clinical vignette, as they are specifically chosen to guide you toward the correct diagnosis and differentiate it from other possibilities. This type of question tests not only your knowledge of infectious diseases, but also your ability to synthesize patient history and physical exam findings into a coherent clinical picture, a fundamental skill for any advanced practice provider. Here is the question for you to consider. A 4-year-old child is brought to the clinic with a 3-day history of low-grade fever, malaise, and a distinctive slapped cheek rash on the face. The mother also notes a lacy reticular rash that has appeared on the child's trunk and extremities. The child is otherwise well-appearing and has no significant past medical history. Based on this presentation, which of the following is the most likely causative organism? Is it A, Streptococcus pyogenes, B, Parvovirus B19, C, Rubeola virus, or D, Coxsackie virus? Take your time to think through these options. As you deliberate on the answer, let's break down the clinical information we've been given. The patient is a 4-year-old, placing them squarely in the age group for common childhood exanthems. The key features are the low-grade fever, the initial slapped cheek appearance, followed by a lacy or reticular rash on the body. This specific sequence and description of the rash are crucial diagnostic clues. Think about what you know about each of the potential pathogens listed in the options. Consider the typical presentation of strep throat with its scarlatiniform rash, the high fever and Koplik spots of measles, and the hand, foot, and mouth distribution of Coxsackie virus. How do those compare to the symptoms described here? Remember, the FNP exam is designed to assess your ability to function as a safe and effective primary care provider. This includes recognizing hallmark presentations of common illnesses. The slapped cheek rash is a classic, almost pathognomonic sign for a particular viral infection. Your ability to immediately associate this sign with the correct virus is what the test is evaluating. This question isn't just about rote memorization, it's about pattern recognition. By locking in this association, you are better prepared to diagnose, manage, and provide appropriate patient education, such as advising on the infectious period and reassurance about the self-limiting nature of the illness. Let's move on to our 7th question. This one will test your knowledge of pharmacology and evidence-based guidelines in the management of a very common chronic condition seen in primary care hypertension. As an FNP, you will be initiating and titrating antihypertensive medications daily. So a firm grasp of the first-line agents is absolutely essential for safe and effective practice. This question requires you to apply the latest clinical practice guidelines to a specific patient scenario. Remember to consider the patient's comorbidities and demographic factors, as these are critical in selecting the most appropriate initial therapy. The question is as follows. A 58-year-old African-American male presents for a follow-up visit. His blood pressure today is 152/94 millimeters of mercury. He has a past medical history of type 2 diabetes, and his recent lab work is unremarkable, with normal renal function. According to the JNC 8 guidelines or more current recommendations, which of the following would be the most appropriate initial medication to prescribe for his hypertension? Your options are A, lisinopril, B, metoprolol, C, hydrochlorothiazide, or D, amlodipine. Take a moment to think this through carefully. As you consider your choice, let's dissect the important elements of this clinical vignette. We have a 58-year-old patient. His race is specified as African American, and he has a significant comorbidity of type 2 diabetes. His blood pressure reading of 152 over 94 millimeters of mercury clearly indicates stage 2 hypertension, requiring pharmacological intervention. The key to this question lies in integrating these pieces of information. The guidelines for hypertension management have specific recommendations based on race and the presence of comorbidities like diabetes or chronic kidney disease. This is not a one-size-fits-all decision, and the exam is testing your ability to provide personalized, evidence-based care. Think about the major classes of antihypertensive drugs. ACE inhibitors like lisinopril are often considered for patients with diabetes due to their renal protective effects. Beta blockers like metoprolol are generally not first line unless there's a specific indication like post-myocardial infarction or heart failure. Thiazide diuretics like hydrochlorothiazide and calcium channel blockers like amlodipine are also recommended as first-line agents for the general population. The crucial factor here is how these recommendations are modified for an African American patient. Recall the evidence from major clinical trials that informs these specific guidelines. We've arrived at question number 8. This scenario will take us into the realm of women's health, another cornerstone of family practice. The question focuses on the diagnosis of a common and often distressing condition. Your task is to identify the correct diagnosis by applying specific clinical criteria. This requires careful attention to the details of the patient's history and reported symptoms. Women's health questions on the FNP exam often test your knowledge of diagnostic standards, such as the AMSL criteria or the criteria for polycystic ovary syndrome, so being familiar with these is absolutely vital for your success. Here is the question. A 28-year-old female patient complains of a malodorous vaginal discharge that is more noticeable after intercourse. On examination, you note a thin, grayish-white, homogeneous discharge coating the vaginal walls. A wet mount preparation reveals epithelial cells with obscured borders, and the pH of the vaginal discharge is 5.5. A whiff test performed by adding potassium hydroxide to the sample produces a distinct fishy odor. Which diagnosis do these findings support? The options are A. Trichomoniasis, B. Bacterial vaginosis, C. Vulvovaginal candidiasis, or D. Atrophic vaginitis. Let's break down the clinical evidence presented. We have a 28-year-old female, so we are less likely to be thinking about post-menopausal conditions initially. She reports a malodorous discharge, which is a key symptom. The physical exam reveals a specific character to the discharge: thin, grayish-white, and homogeneous. Then we have the objective laboratory findings, which are the most critical part of the question. The presence of epithelial cells with obscured borders on the wet mount, a vaginal pH greater than 4.5, and a positive whiff test. These three findings are part of a well-known set of diagnostic criteria. As you evaluate the options, think about the classic presentation of each one. How does trichomoniasis typically present? What are the hallmark signs of a yeast infection or vulvovaginal candidiasis? Consider the typical patient and symptoms for atrophic vaginitis. Your goal is to match the constellation of signs and symptoms from the vignette, the discharge character, the pH, the wet mount findings, and the whiff test result to the single best diagnosis. This question is a direct application of clinical diagnostic criteria, a skill you will use frequently in your practice as a family nurse practitioner. All right, team, we're nearing the finish line. Let's tackle question number 9. This one delves into the realm of pediatric care, a critical component of the FNP scope of practice. Pay close attention to the details in the clinical scenario, as they are specifically designed to guide you toward the most appropriate diagnosis and subsequent management plan. Remember, in pediatrics, age-specific presentations and developmental milestones are often the key to unlocking the puzzle. This question will test your ability to differentiate between common childhood illnesses based on a classic constellation of signs and symptoms. Are you ready? Let's dive in and see how well you can apply your knowledge to this pediatric case. Here's the question. A 4-year-old child is brought to the clinic with a 3-day history of high fever, reaching up to 104 degrees Fahrenheit, or 40 degrees Celsius. The parents report that the child has been irritable and has a poor appetite. On examination, you note conjunctivitis without exudate, a bright red strawberry tongue, and erythema of the palms and soles. The child also has a diffuse maculopapular rash on the trunk. Which of the following is the most likely diagnosis? Is it A. measles, rubeola, B. scarlet fever, C. Kawasaki disease, or D. roseola infantum? Take your time, analyze the symptoms presented. I'll give you 30 seconds to think it over. Let's break down the clinical picture we've been given. We have a very high fever, which is a significant and alarming sign in any young child. This isn't just a low-grade temperature, it's a persistent, high-grade fever that immediately signals a serious underlying process. Then, we add the irritability and poor appetite, which are non-specific, but tell us the child feels quite unwell. The more specific clues are the physical findings: the bilateral conjunctivitis without any pus or discharge, the classic strawberry tongue, the redness on the hands and feet, and the truncal rash. Each of these is a puzzle piece. Your task is to see how they fit together to form one coherent diagnosis. Consider the options carefully. Measles or rubeola typically presents with the 3 C's: cough, coryza, and conjunctivitis, along with Koplik spots, which were not mentioned. Scarlet fever is associated with a streptococcal infection and presents with a sandpaper-like rash and a strawberry tongue, but the non-exudative conjunctivitis and erythema of palms and soles are less characteristic. Roseola infantum is known for a high fever that breaks as a rash appears, but the other specific signs are absent. Think about which condition uniquely combines all the elements described in the vignette. The clock is ticking. We have arrived at our final question for this review session. Question number 10. This one will focus on pharmacology and the management of a common chronic condition that you will undoubtedly encounter on a daily basis in primary care. This question is designed to test your understanding of first-line therapeutic agents, their mechanisms of action, and most importantly, their potential side effect profiles. As an FNP, your role isn't just to prescribe, but to educate, monitor, and manage the entire patient experience with their medication. This scenario will require you to connect a patient's complaint directly to a well-known adverse effect of a widely used medication class. Let's get to it. Here is question number 10. A 62-year-old male with a history of hypertension and type 2 diabetes mellitus, which are managed with lisinopril and metformin respectively, presents to your clinic for a follow-up. He reports developing a persistent, dry, non-productive cough over the past 2 months. He denies fever, shortness of breath, or any recent upper respiratory infections. His physical exam is unremarkable, and his lungs are clear to auscultation. Which of the following is the most likely cause of his cough? Is it A, a common cold, B, postnasal drip, C, lisinopril, or D, metformin? Take 30 seconds to consider the patient's history and medications. As you ponder the possibilities, let's carefully evaluate the information provided. We have an older adult male with 2 very common chronic diseases, hypertension and type 2 diabetes. His medications, lisinopril and metformin, are cornerstone, first-line treatments for these conditions. The chief complaint is a very specific type of cough. It's persistent, it's dry, and it has been going on for 2 months. The patient's denial of other associated symptoms like fever or congestion and the normal lung exam are crucial negative findings. This helps you narrow down the potential causes significantly, moving away from infectious or allergic etiologies. Think about the timeline. The cough developed gradually and has been present for 2 months. This chronicity makes an acute cause like a common cold highly unlikely. Postnasal drip is a common cause of chronic cough, but it often comes with other symptoms like a sensation of dripping in the back of the throat, frequent throat clearing, or evidence of rhinitis on exam, none of which are mentioned here. Now, turn your attention to the medications. Could one of these be the culprit? This is where your deep knowledge of pharmacology becomes your greatest asset. One of these medications is famous for causing this exact side effect. And that brings us to the end of our top 10 must-know questions for the FNP exam. I truly hope you found this review session challenging, informative, and most importantly, helpful in building your confidence. Remember, every question you practice, every rationale you understand is another solid step toward that FNPC or FNP-BC credential you are working so hard to achieve. The journey to becoming a family nurse practitioner is a marathon, not a sprint, and consistent, focused preparation is what will get you across that finish line. These questions are just a sample of the high-yield topics you need to master. This has been Knowles Review, your dedicated partner in FNP board preparation. We believe that the key to success is not just memorizing facts, but truly understanding the clinical reasoning behind every decision you make. Our goal is to provide you with the highest quality, most relevant, and most engaging content to make your study process as effective and efficient as possible. We are committed to helping you walk into your exam feeling prepared, capable, and ready to demonstrate your expertise. We are proud to be considered the best online FNP review available. If you found this video valuable and want to continue sharpening your clinical skills, please do us a huge favor and hit that subscribe button below. By subscribing, you'll be the first to know when we release new videos packed with more practice questions, in-depth topic reviews, study strategies, and essential tips to help you ace your FNP boards. Don't forget to also click the notification bell so you never miss an update from us. Your support allows us to keep creating this free content for aspiring FNPs just like you. Thank you so much for studying with us today. Keep up the incredible work, stay focused on your goals, and remember that every moment you invest in your education is an investment in your future patients. Leave a comment below to let us know which question you found most challenging or what topics you'd like us to cover next. We read every single comment and love hearing from our community. This is Noelle from Knowles Review, wishing you all the best on your journey. We'll see you in the next video.